Welcome to Community Watch, and today we're talking to John Quinlivan, the CEO of Redmond Medical Center. Stay tuned. Community Watch starts now.
Welcome to Community Watch. Greg, how are you?
I'm fine. Just had a coronavirus test. I'm doing well.
You're having about 2 a day now, aren't you?
If that's going to keep me safe.
Well, keep us updated with that. I've had one. Maybe I'm due for another. I don't want to be too far behind you.
Well, I suggest doing one periodically nowadays.
Yeah. Well, we're very happy to have with us today John Quinlivan, who is the CEO of Redmond and beyond. Welcome to the show.
Thank you. Pleasure to be with you.
So, help us understand all that you have to worry about in your job, because it's not just Redmond that you deal with.
Well, it's primarily Redmond, and we're all part of Redmond. We have the hospital. We have an emergency medical service which supports 3 counties: Floyd, Polk, and Chattooga County. We also have outpatient practices spread across that area. We have an occupational health service that supports a number of local industries, and then we have a graduate medical education program with an internal medicine residency program and a transitional year internship program. So great group, and honestly very little to worry about because it's just such a great group of folks that I work with.
Well, I'm glad that you have a great team, because these are definitely challenging times. And I guess we need to begin with just a discussion of Redmond's experience with COVID-19 and how things are going currently.
And before I do that, let me brag just a minute. Just last week, we learned that we were named to the top 100 hospitals list. I'm sure you're familiar with that program. Every year, the 100 best hospitals in the country are identified. We were delighted to be named the only hospital in Georgia to make the top 100 list. So that's pretty significant.
Wow, that's great.
Creators of the list advertised that if everyone was treated in a top 100 hospital, over 100,000 lives would be saved and $8 billion of costs saved. So again, we were very proud to make that list. So with that, I'll jump into COVID, which is a better story than I think what you would tend to believe if you just kind of watch the national media. We have 7 COVID positive patients in the hospital right now. Our high had been about 13. We trended down in the past couple of months to the point where we reached 0. We had no cases the first part of June for a couple of weeks, and then we began ticking back up again. And it's interesting, this was all predictable. We knew it would happen when we reopened, and we needed to reopen. I'm not advocating against that. We absolutely need to reopen. We need to be a little more careful as we do that, though. But as we ticked back up, what's been interesting is it's a different population of patients. The first time around, the patients were old, largely older. They were very sick and generally didn't do well. And that's been the experience across the country. What we're seeing now is generally somewhat younger patients. They don't stay in the hospital nearly so long. They tend to do pretty well. In fact, of the 7 patients we have in the hospital right now, only 1 is on a ventilator. And previously we had a much higher portion of patients on the ventilator. I've talked to some of our physicians and some of our nurses about the differences, and what they're saying is that, and this is speculation, but I think it bears out. The first time around, we were seeing older patients with comorbid conditions who, we didn't expect this. They didn't know that they needed to be sheltered and staying away from people. Well, they know that now. And so the folks who are most vulnerable are sheltered. And the folks who we're seeing now are, as I said, generally younger and healthier. They're the folks who are getting out and are interacting. And while most of those who contract COVID have very mild symptoms that don't require hospitalization, there is some small percentage of them that do require hospitalization. And that's what we're seeing now.
Let me ask you, given that only a few folks who are who have the virus end up in a hospital, what makes that decision? I mean, when is it necessary for somebody to be in the hospital or to go to the hospital?
Well, I mean, it's an individual judgment in terms of when should you go to the hospital. When should you seek treatment? Just as with any other illness, and it's going to vary, but when you feel significantly short of breath, when you're running a high fever, those are the times that you're probably going to come in. Our physicians use a number of indicators to determine when someone needs to be admitted. Again, the first time around, it was largely the frail elderly, and the threshold for admission in a population like that is pretty low. So again, now it's largely oxygenation. This is a respiratory illness, and we're seeing folks with pretty low oxygen saturation levels, and that's one of the key indicators. And an interesting thing, that you look at O2 sats, they call it, to determine when you need to put a patient on the ventilator. Now, it's much more complicated than that, and a physician could tell you far better than I can how that works. But what we've found is that COVID patients are able to maintain their function at lower oxygen saturation levels than most patients would. And in fact, we've begun to delay putting them on ventilators, but again, because they can sustain themselves at lower oxygen saturation levels more than or better than patients with other illnesses. So, and folks who have gone on the ventilator largely have not done real well. So we're trying to keep them off the ventilator if we can.
And I know, we've talked to several individuals at different levels who've been working with preparedness for the virus. I'm just wondering, at Redmond, did you have a number of patients you anticipated to be there?
We did. That's a great question. I appreciate you asking it. Initially, we were told to expect patient volumes 3 to 5 times what we normally experience, which would have totally overwhelmed us. And it would have overwhelmed both hospitals in Rome. And that was based on the experience in Wuhan, China, and the initial experience in Italy. When we look back in that now in retrospect, we realize it was really unreasonable to think that it would have ever been that high, given just the nature of our community and geographic dispersion that we have. But at any rate, we took that seriously, and we prepared seriously to accommodate that. We came up with plans to almost double the hospital's capacity in a crisis kind of a situation. We had staffing plans. We had worked with Harbin Clinic, and we had plans to expand our house-based physician staffing by using specialists, pressing them into roles as critical care doctors and emergency medicine doctors. And I think you saw the tents in the parking lot and that kind of thing. And, fairly early on, we recognized that this tsunami of cases that we were advised to expect wasn't materializing. And we began to realize that it wasn't likely to materialize. And while there is still the possibility that that could happen, I think it's fairly unlikely. And so really the challenge became not so much COVID as it was fear of COVID. And we have seen people suffering terribly and unnecessarily of non-COVID related medical problems that are becoming very serious because they're not attending to them because they're afraid to come into the hospital or they're afraid to go see the physician. And in fact, I've got some, just a couple of stories that I'll share with you on that. One real tragic story, a young woman, 24 years old, in one of our adjacent counties. Family called our emergency medical service. They responded to the home, could not convince this young woman who was very ill to come to the hospital. Couldn't convince her to come to the hospital. So left. 2 days later, they're called back to the residence. At this time, the woman is incapacitated. They brought her into the emergency room. They intubated her immediately. She went up to our ICU. 6 hours later, she died. 24-year-old woman. It was a bacterial infection. It was completely treatable. She didn't come to the hospital because she was afraid of COVID. A 24-year-old woman's likelihood of dying of COVID is almost nil. I mean, it is almost zero. But this young woman has now passed. She has a 2-year-old child that now doesn't have a mother. I mean, it's a terrible, terrible tragedy. And that kind of thing is going on, really, I was going to say across the country, but around the world. And one more story, and my EMS director, Marty Robinson, gave me these numbers yesterday. Last year, from June 1st to July 5th, our emergency medical service responded to 8 cardiac arrests cases. During the same time period this year, they responded to 26 cardiac arrest cases. So more than 3 times as many. And that's a function of people ignoring symptoms and not coming to the hospital, again, because they're afraid of COVID. As Dr. John Hostetler, our infectious disease doctor, said, the hospitals are actually probably the safest places in Rome to be. During this whole ordeal, and through tens of thousands of patient interactions here at Redmond, we've not had one staff member contract COVID through a hospital source, nor have we had a patient contract COVID through a hospital source. So, I mean, I think we've done a really good job. We're all wearing our masks. I mean, and we're practicing social distancing. We have our hand gel, and so we're doing all the things that I wish our community would do. And if they would, we'd be in a much better situation.
Well, I'm going to ask one more, and then I know Greg has a dozen, and I won't be able to work my way back in again. But I am curious about folks who just need to go to an office over there for a check or what they would normally do, who, as you say, have been afraid to because of COVID. What are there, I guess, universal precautions that are being made throughout those offices with individual physicians, or is it up to each individual office? I mean, how is that being handled?
No, it's standard. I mean, when you come in, we'll check your temperature. We'll ask if you've had any symptoms. We'll ask you to put on a mask, and we will space you apart. We're trying to make sure that we create social distance. Now, I'll tell you, just in the last few days, we've seen our volume pick up significantly, and we've had folks crowding together more than we would like them to. So we are trying to separate them. But that's another really good question. I'm glad you asked it, because one thing I would advocate for anybody is the 3 W's, if you think about it. Wash your hands more than you normally do. Watch your distance. Ideally, you want to stay 6 feet or so from other folks. And most importantly, number 3, wear a mask. If we would all do those things, again, we would see the incidence of COVID drop markedly.
All right, Greg, we only have a minute left. So you better not ask anything too complex now. We're coming up on a break here, but as soon as we come back, we will have more discussion with Mr. Quinlivan, and you don't want to miss that. So don't go away. We'll be right back after this.
Your life is filled with opportunities to show the world you can take charge. It's waking up each day with a mission. It's working each day toward a goal. It's choosing to rise. It's charging forward with a purpose. It's changing the course of your life and taking charge of your future. If you're ready to be a Take Charger, enroll at Georgia Highlands College today.
Welcome back to Community Watch. We're having a conversation with John Quinlivan, the CEO of Redmond Hospital. And Mr. Quinlivan, you mentioned that younger folks who are being tested positive are not having especially dangerous reactions. They are recovering from the virus much more easily. And I wanted to ask, and this is, I guess, a subjective question, but I wanted to ask if you felt that that was the reason that we're seeing so few young people wearing masks and taking precautions, because it just doesn't seem to be a disease that affects them. But they still need to do that, don't they?
Yes. Among the young adults, definitely. Children are not a significant source of virus spread, which, by the way, is one factor arguing for restarting schools. I was early this morning swapping emails with Jeff Wilson, the county school superintendent. Absolutely need to restart schools, I believe, and I think Jeff wants to do that too. So they're working to figure that out. Children are not a significant spreader source. Now, young adults can be, and while they typically, when they contract the disease, many of them, in fact, the majority of the younger folks don't even have symptoms, and those who do tend to have minor symptoms. Now, there are some exceptions. There are some people, particularly those with comorbid conditions, who wind up having significant illness even at young ages. But by and large, the young folks are minimally impacted. And yeah, that probably does impact their willingness or lack thereof to wear a mask. Now, another factor, though, is there's a latent period of 5 to 7 days on average, but sometimes as much as 14 days from the time that you actually contract the virus until symptoms manifest. And so there's a delay between, I think, exposure and punishment, if you will, and that makes behavior change, I think, harder. So it's a real challenge. We're meeting with the city and county commissions this afternoon, and I know one of the issues we're going to discuss is whether there should be mandatory masking, and I feel very strongly that there should be.
I am assuming one of the primary reasons for that is that those young adults could certainly easily infect older family members or just individuals they come across. Absolutely.
Yeah. In fact, actually, most transmission occurs in the household. When you look at tracing back infections, most of it is from someone that you live with. So, yeah.
All right, Greg, I'm giving you an in here.
Really? I guess my biggest question is with all of this going on, I know we get into this whole mandate about masks, where people should not wear masks, but what are you recommending as a health professional? What are y'all recommending from Redmond as far as people wearing masks?
Well, if you come into Redmond, you got to wear a mask. If you don't want to wear a mask, you can't come in. And I honestly kind of think that needs to be the policy in the community. If you're in a situation where social distance is not possible, or you can't guarantee social distance, then we need to require masks. I wear my mask to protect you. What if you don't wear your mask? I mean, that again, it's almost like, my right to swing my hand stops where your nose begins, Well, now, I can, from 6 feet away, potentially infect you. And so, I think that the choice we have is to lock down again, which is terrible. We absolutely don't need to do that. Or let's give up a little bit of liberty. Let's agree to wear masks, because we can wear masks and we can pretty much go about our normal business. And that's the much lesser of the two evils, I would say.
In saying that, which makes a lot of sense, is it well, I guess it seems like to me when I walk around the community, I'm seeing like people are very lax and not a lot of mask wearing.
That's right.
Do you think as a community, because we don't have such high numbers, people just don't take it as serious?
I do, yes. I think that as the incidence goes up, you do see maybe the community become a little more aware and you see more masking. But I don't know if you were by any of the testing sites in the last few days. I know you are now. they've been overwhelmed in the last few days. So I think there's a very high level of anxiety as people now see it spreading. And this is a result of our behavior over the last few weeks. We got out, we re-engaged, we kind of dropped our guard. And so there's been a lot of exposure. And every day you delay, it just magnifies the problem. So, there've been repeated studies in other communities where they've looked at the impact of masking. And just off the top of my head, the most recent one I saw demonstrated that mandatory masking reduced the incidence of COVID by about 40%. And that's material. So, and by the way, another study, if 80% of the population would wear masks, we wouldn't need to do anything else. That alone would be more effective than a total lockdown. So 80% of the folks wear masks, you're more effective than just locking everything down like they did in China.
So let me get this straight then. So really, if we were just more proactive about wearing masks,
absolutely,
that would be more effective than the lockdown itself.
Absolutely. Wash your hands, although fomites, contaminated surfaces, are not a significant source of spread. Wash your hands, watch your distance, and most importantly, wear a mask.
It seems so easy. It just amazes me that people are not willing to do that. It's just a small thing.
I think, again, folks tend to think, well, it can happen to others, but it can't happen to me. And even if it does happen to me, I'm healthy, and so it's not going to be a big deal. Again, the folks that we need to think about are our grandmothers, our grandfathers, our parents, the folks who may be older and vulnerable, frail, those with comorbid conditions. And we just all have to consider them.
I wanted to ask too. We are so fortunate to have the hospitals and other medical offices in this area. But I know there must be challenges with having two big hospitals and within just a couple of miles of each other. And do y'all routinely coordinate and work together? There must be some confusion there too.
We do to some degree, not routinely. Honestly, during the COVID era, we've done that more than I've been here for 10 years, and we've done it more during this COVID period than we have prior to that. Now, we've recently had a somewhat public spat, and those kind of things make it hard to work closely when you need to. But this is a time when we need to come together. Harbin Clinic has been great. The leaders of Harbin Clinic have kind of helped orchestrate things, and we have met often as a medical community, and often with our formal community leaders, our city and our county commission. So we'll continue to do that.
Yeah, I'm curious though. For most, I'm guessing for most patients and potential patients, I don't know how many are aware of which hospital has the capability of doing this as opposed to something else. So if an individual has an issue, if they call an ambulance, how do they know where they need to go? How does that work?
Well, they might not. If they talk to a physician, generally the physician can advise them. We have the open heart program. That's been the most recent issue, and I'd love to talk about that. The cardiologists tend to bring if they are concerned about a cardiac cath case that they're doing, they'll do that at Redmond, so that if open heart surgery is necessary, they can do it right here. Every month we have a number of patients that are transferred emergently from Floyd to Redmond for open heart surgery. So we're known as a heart hospital, and for good reason.
Well, please feel free to tell us a little bit about the heart treatment.
Yeah, I will. So Floyd filed a certificate of need to try to add open heart surgery about 2 years ago. There are objective criteria that you need to meet in order to qualify for that. Those criteria are that you have to have a cardiac cath program that's been in effect for 3 years or more. They had that. That cath lab should produce 250 open heart surgeries a year. That is, cases where the cardiologists go in, they take a look, they realize this patient's not a candidate for a cath, they need to go to open heart surgery. You need to generate 250 of those a year. Floyd generates about 63 a year. You must demonstrate that within 3 years of starting the program, you'll be able to do 300 or more open heart surgeries a year. They could not demonstrate that. And you have to demonstrate that as you grow your program, you won't take more than 10% of your volume from any other hospital, and they couldn't. Their own analysis demonstrated that about 40% of their volume would come from Redmond. The biggest argument against doing another program at Floyd, though, is that you would take one strong, viable program at Redmond, which is over 400 cases a year, and you would divide that into two smaller, probably non-viable programs. The state threshold is 300 cases a year. Both programs would be doing in the 200 range if you had two programs. Let me give you an example of the resources that would be challenged. 10 years ago, there were over 4,000 cardiac surgeons in this country. Today, there are less than 3,000 cardiac surgeons in the country. We're recruiting right now to replace Dr. Dan Goldfaden. And we're really struggling to find folks because there are just fewer of those. They're very limited resources. And so that's, the biggest reason to not do it is that you would take one strong, viable program and you would create two weak and questionably viable programs. Dan Goldfaden said that, by the way, in the letter that he wrote to the paper. You might have seen that.
I know, and correct me if I'm interpreting this wrong, but I seem to remember that one of the issues was that Floyd felt they could serve the community in new and different ways. I don't know if that's an issue that has come up before, or is that something to speak on?
I'm sorry, it's hard not to get angry about this because there was a lot of misinformation. In fact, there was a lot of information that was 180 degrees from what the true facts are. We had a meeting a couple of weeks ago with a group of about 24 African-American community leaders, and got great support from them. We shared the full story, all the facts, which are out there. We both have them. And I think there were several folks who even said they regretted having signed the petition because they didn't know the full story. So yeah, there's a lot to this. And I can talk all the numbers if you want to. I can talk them off the top of my head. We've been doing this so long, but when you're dealing with something like COVID, and when you're dealing with a serious issue like the racial injustice that we are now acutely aware of in the wake of the George Floyd shooting, to have a situation like this brought up in our community, I think is just a travesty, and I think it diminishes from the broader, more important work that we're trying to do. And I think many in our community recognize that, and so I think this whole campaign, kind of backfired a little bit on Floyd.
Well,
John, but let me do so. I know we got about 30 seconds.
Go ahead.
But to John Q, I have to say, as I told Kurt though, but I do think outreach in the African American community, absolutely, it can be better. There's more things we can do.
Sure,
because we know African Americans are dying of treatable diseases.
Absolutely, you are absolutely right, Greg. Both hospitals, I think, can do a better job of that. Yeah, in all the minority communities, in fact. Yeah.
We unfortunately are totally out of time, but we hope you'll come back with us again sometime. We can talk more.
Pleasure talking with you both.
And thank you out there for being with us on Community Watch. We'll see you next time. Bye now.